to be speaking on addressing tobacco in behavioral health settings. This is my disclosure information. The objectives for this talk are to describe the prevalence and consequences of tobacco use and mental illness, and then to look at aspects of assessing tobacco use disorders, including DSM criteria, the time to first cigarette in the morning, and readiness to change. We'll also see how carbon monoxide measurements are a valuable aspect of assessment and giving smokers feedback when available. We'll also look at an introduction to treatment in terms of brief interventions, counseling strategies, and approaches to tobacco as a co-occurring disorder. It's estimated that there are about 51 million cigarette smokers in the U.S. today, and that at least 1/3 of these have a mental illness. Cigarette smoking rates are about 20% in the general population, but they're estimated at least to be about 40% in populations with mental disorders, with high rates among subgroups with anxiety disorders, depression, substance use disorders, and psychosis. Of concern is that although smoking rates continue to go down in the general population, you can see the trend here from 1997 to 2011, where smoking rates in the general population continue to decline at a rate of about 0.5% per year. We don't see that same trend in individuals with serious mental illness, where rates have remained stable in the 40% range. This suggests that interventions aimed at reducing smoking in the general population, public health measures, for example, are not effectively reaching this population. Cigarette smoke is toxic to the human body, and the old saying, "It's the smoke that kills," is actually very informative when we remember that cigarette smoke contains more than 7,000 different chemical compounds, some of which are listed on this slide. Of the 7,000 chemicals, at least 65 are known to cause cancer, toxic substances including benzene and nitrosamines. It's important to understand the source of tobacco toxins. Nicotine, for example, is naturally occurring in the tobacco plant, but so are nitrosamines, and nitrosamines are one of the most potent carcinogens related to tobacco use. This is important when people say that they use roll-your-own tobacco or organic tobacco or tobacco that they purchase from different places that they may believe is a safer alternative form of tobacco. Well, that can't be true since nitrosamines are in fact in the plant. During the manufacturing process, chemicals are added that change the way tobacco smells, tastes, and burns, but by far, most of the chemicals come when tobacco is put on fire. When tobacco burns, thousands of new chemicals are formed, and these are some of the most toxic things in cigarette smoke, including carbon monoxide, formaldehyde, etc. Data has shown that people with serious mental illness die on average 25 years earlier than the general population, and of great concern in these studies are that many of the illnesses are related to tobacco smoke exposure. If we look at the top 4 causes of death in people with mental illness, they are heart disease, cancer, stroke, and COPD, all of which are highly linked to smoking. Efforts to reduce cardiovascular disease should emphasize smoking cessation, since smoking cessation produces the greatest reduction in risk from cardiovascular disease. You get a 60% risk reduction in cardiovascular disease by quitting smoking, which in fact has a greater impact than other risk factors, including reducing blood pressure, cholesterol, increasing activity, or maintaining ideal body weight. And a recent statistic confirmed what many of us suspected, that indeed half of all of the deaths in people with schizophrenia, depression, and bipolar disorder can be attributed to tobacco, making this the #1 cause of death in people with mental illness. In addition to health consequences, there's many other consequences that people experience as a result of tobacco use. Smoking is a barrier to community integration and impacts a range of activities, including getting a job and seeking housing. There's evidence that employers prefer to hire non-smokers due to reduced insurance costs and because of the higher productivity associated with non-smokers. This is an analysis that shows that individuals with schizophrenia spend at least 27% of their monthly disability check to purchase tobacco, which is a considerable portion of their income, making less money available for other basic necessities, including food and shelter. Reduced income will have an impact on reduced quality of life. And it will be increasingly difficult to find housing if you're a cigarette smoker. There's a national movement towards smoke-free public housing, which is being endorsed by the Federal Office of Housing and Urban Development. It's not yet a requirement, but it may be at some point. This would, in fact, say that you couldn't smoke in your own home if you lived in a multi-unit dwelling of public housing. And the reason behind this is because much of the air in multi-unit housing comes from the other units and is shared among the space, and secondhand smoke, in fact, infiltrates air ducts, stairwells, elevator shafts, etc., and is a risk to everyone who lives in the building. Secondhand smoke is a carcinogen in the same class as asbestos. There used to be concerns that helping patients quit smoking would have a risk on worsening their mental illness. However, the newest research suggests that this is not true, that in fact quitting smoking is associated with improved mental health outcomes. So this was a meta-analysis looking at 26 studies showing that when people are able to quit smoking, if you assess them 6 months later, that indeed anxiety goes down in the context of quitting smoking, depression goes down, stress levels go down, quality of life is enhanced, as is positive affect or positive mood. Really supporting, again, that quitting smoking is associated with improved mental health status. Tobacco use disorder is a diagnosis included in the DSM-5. Tobacco use disorder is in the DSM-5 because it is indeed an addiction. When you use the drug of nicotine, nicotine impacts the brain and the brain reward pathways much in the same way as cocaine and heroin, therefore underscoring nicotine as a true addiction. If we look at the availability of tobacco cessation services in this country, it's quite poor if you have a mental illness. Only 1 in 4 mental health treatment facilities offers quit smoking services, and this is a fairly recent analysis put out by SAMHSA of almost 10,000 mental health facilities in the United States. The state hospitals have done quite a bit to reduce smoking, and almost 80% of state psychiatric hospitals are currently tobacco-free, which means they have no smoking on the premises. However, it is of concern that less than 35% of these hospitals actually report treatment availability for tobacco users. So it's fine to have policies that restrict tobacco use in the environment, but we should do these in addition to having treatment available for tobacco users. This is a statistic showing that less than half of U.S. substance abuse treatment facilities include services for tobacco addiction. In terms of how to access tobacco treatment, we would hope that there's no wrong door. So although traditionally tobacco has been addressed in the primary care setting, it may make more sense for it to be addressed in the behavioral health setting, where in fact we see patients more intensively for more visits. Visits are often longer in terms of minutes, and people who work in behavioral health often have a great deal more experience and training in the treatment of other addictions. We're counselors and experts in psychosocial treatments, and we can also assess mood and other changes that may come as a result of addressing tobacco. In fact, we can look at principles for treating co-occurring disorders and see how they match quite well in how we might approach a tobacco use disorder in the mental health setting. So principles of co-occurring disorders say that we should provide integrated services for addiction in the mental health setting. Services should be comprehensive and matched to the motivational level of the client. They often take a long-term treatment perspective where we do continuous assessment of substance use, we provide motivational interventions, and then additional services like psychopharmacology, case management, and housing can be important adjunct and supports to the co-occurring treatment approach and help the person to achieve sobriety. These same aspects of assessment and treatment can be applied to the use of tobacco use disorders and the integration of tobacco treatment into mental health settings. So briefly, I'll talk about treatment. Essentially, treatment for tobacco use disorder works and can include a range of brief assessment interventions. Treatment should include both counseling and medication, and overall we can think of approaching this like a co-occurring disorder. These are the DSM-5 criteria for tobacco use disorder. In the DSM-5 edition, the diagnosis was changed from nicotine dependent to tobacco use disorder, although the criteria are largely the same. The only change is the addition of craving as a new criteria. One way that this substance use disorder is different than other patterns of substance use is that most people that use this drug are in fact addicted. They meet dependence criteria for the use disorder. Contrast that to the way alcohol is used in our population, where many people use alcohol and actually few have an alcohol use disorder. This substance is characterized by most people meeting criteria for a tobacco use disorder. These are the symptoms of tobacco withdrawal. They would result from the abrupt cessation of tobacco, or can also happen with reduction lower than the usual amount, and includes any combination of 4 or more of these symptoms: depressed mood, insomnia, irritability, anxiety, difficulty concentrating, restlessness, and increased appetite. It's very likely that these symptoms are seen throughout the day while someone may be receiving treatment in a behavioral health program, because these can emerge even hours after the last cigarette. It's also likely that this diagnosis is often missed in a behavioral health treatment setting, because although this is a real syndrome, the symptoms are not that specific and can overlap considerably with other types of mental disorders. One of the key questions then, in assuming that most people are in fact dependent on this substance, is to understand the severity of dependence, which can be assessed using the heaviness of smoking index. One of the best questions you can ask a tobacco user is how many minutes in the morning until you smoke your first cigarette. This is referred to as the TTFC, or time to first cigarette. Anyone who smokes in the first 30 minutes of waking up in the morning is at least moderately nicotine dependent. And in fact, many clients will report smoking within the first 5 minutes of waking up in the morning, which is an indicator of higher levels or more severe levels of nicotine dependence. You can also assess people based on the number of cigarettes per day smoked. The higher the number in general, the more addicted someone is. However, the TTFC is actually a more sensitive measure for understanding the level of dependence and yields a lot of valuable clinical information with a single question. If we look at populations with mental illness, there's evidence that they are more addicted than other smokers in the population that don't have mental illness. So this, for example, is population data showing that smokers with depression smoke more cigarettes per day and are more dependent than smokers without depression. So shown on this slide as more smokers with depression are smoking within the first 5 minutes of waking up in the morning and also reporting a higher number of cigarettes per day smoked. Smokers with serious mental illness also have evidence of high levels of tobacco dependence. On one side of the slide here, we see a sample of 100 outpatients with serious mental illness, 50% reporting severe levels of nicotine dependence, smoking in the first 5 minutes of waking up in the morning, and 80% meeting criteria for moderate to severe levels of dependence. This is also seen in population data, where populations with serious mental illness have higher levels of nicotine dependence assessed by various methods, questionnaire, and also by using the question of time to first cigarette. Assessment of carbon monoxide is another important aspect of tobacco assessment. If you're able to access a carbon monoxide meter, carbon monoxide is a product of combustion and comes from anything that burns, including cigarettes. Smokers may be aware of what carbon monoxide is, but not realize that every puff of a cigarette puts carbon monoxide directly into the body. When carbon monoxide is in the body, what it does is attach very strongly to red blood cells and displace oxygen. This creates burden on the heart and reduces overall oxygenation, which is a risk factor for heart attack and coronary artery disease. If you're able to have a carbon monoxide meter, you can document smoke exposure in a smoker by having them blow into the meter. Carbon monoxide levels in smokers are generally 10 or more parts per million. But the meter has other uses as well. When people quit smoking, you can use this to confirm abstinence. So one of the best messages of carbon monoxide is that this is in fact completely reversible. The body is creating new red blood cells every 2 to 3 days. So when smokers quit smoking, oxygen levels in the body get back to normal within 2 to 3 days, and the carbon monoxide level drops, say, from 20 to 0. In that way, the number can be motivating to people to see the feedback of how cigarette smoke is harming them today, and how this reversible impact can also be changed in the context of quitting smoking. In terms of approaches to treatment, in general, we think about matching treatment strategies to stages of change. Only patients who are in preparation, ready to think about changing the behavior in the next month or so, should receive action-oriented treatments, what we would traditionally call quit treatment or cessation treatment. Patients who may be less motivated in the pre-contemplation or contemplation stages should receive motivational treatments to help get them ready and move them towards preparation so that they can make an eventual quit attempt. Language can be important, and I would encourage you to think about developing services called tobacco dependence treatment as opposed to calling services smoking cessation, stop smoking, or quit services. These can then be limiting in only being attractive perhaps to smokers in the preparation stage, and if your intent is to engage smokers at all levels of motivation, more general language or more all-encompassing services may offer an advantage. One of the primary modalities for treatment is pharmacological treatment. The rationale for pharmacological treatment is to reduce or eliminate the symptoms of tobacco withdrawal. The medications have other effects as well. They block the reinforcing effects of nicotine. They double the chances of a successful quit attempt. They lessen or delay the weight gain associated with quitting smoking. And in fact, these are a proven cost-effective treatment. There are 7 FDA-approved treatments for tobacco cessation, and they include 5 types of nicotine replacement. These are often referred to as nicotine replacement therapy, or NRT, and 2 non-nicotine treatments, bupropion and varenicline. The best treatment plan, however, for every tobacco user is a combination of counseling plus medication, which produces the greatest success rates in quitting. I'll just make some brief comments about these different medications. There are 5 types of nicotine replacement products: the nicotine patch, gum, lozenge, inhaler, and nasal spray. The patch, gum, and lozenge are all available over the counter without a doctor's prescription. However, there may be situations where you would want to write a prescription for the patient so that they could get this medication covered through their state Medicaid and at no cost. Varenicline works in a different way than the other medications. It actually targets the brain reward pathways based on our understanding of nicotine addiction. So nicotine receptors are located in this part of the brain, the ventral tegmental area, and we know that nicotine activates this part of the brain and causes the release of dopamine in the brain, and that's what causes addiction to nicotine. This medication was developed essentially based on understanding some of this neuroscience. And there's some evidence that varenicline is more effective than the other treatments when used as a monotherapy. So this is a slide showing the overall odds ratio from meta-analysis comparing the effectiveness of these first-line medications. And we see with the first several, nicotine patch, gum, inhaler, nasal spray, and bupropion, that the odds ratio for all of these treatments is 2 or approximately 2. That means that these products double the chances of a successful quit attempt compared to a placebo treatment, demonstrating that they're all effective in helping people to quit smoking. But in fact, varenicline has a higher odds ratio of 3, suggesting again more effective than prior treatments. There's often concern about the possibility of neuropsychiatric side effects associated with the use of varenicline. However, several meta-analyses have now been published which have not shown evidence of significant neuropsychiatric side effects. This is the largest and most up-to-date of these meta-analyses which have been published. This study was not sponsored by Pfizer and included a range of industry and non-industry funded studies. In this large meta-analysis of more than 10,000 patients, there was no evidence that varenicline was associated with a higher risk of suicide, suicidal ideation, depression, irritability, or aggression. Use of varenicline has been associated with a higher risk for sleep disorders, insomnia, and abnormal dreams. And interestingly, in this analysis, varenicline use was associated with lower risk for anxiety. Again, I just want to make the point that the most effective treatment strategy would include a combination of medication plus counseling, that compared to medication alone, the combination of medication plus counseling is more effective in helping people to stop smoking. Similarly, we also see a higher odds ratio for meds plus counseling compared to counseling alone. So counseling and medication, they both work. They're both considered first-line treatments, but we see the greatest impact and the greatest success rates when clients are offered a combination of medication plus counseling. Counseling strategies include a range of skills training, relapse prevention, problem solving, coping skills, stress management techniques. Maximizing social support is also an important part of providing evidence-based tobacco counseling. Luckily, these are services and skills which are already provided in the behavioral health setting, and many providers are already adept at providing these kinds of counseling strategies. Where the core themes are to change cognitions about smoking, reinforce non-smoking behaviors, and help clients to avoid high-risk situations. The Quit Line is another service which may be available. Most states have a Quit Line at this point, which is a toll-free telephone counseling service, often funded by the state. The client receives scheduled calls from a tobacco specialist and can be good in dealing with transportation barriers and other barriers that might keep people from accessing treatment. It's typically a brief service that includes 4 to 5 calls, but has been associated with good success rates in smoking cessation. Again, principles of co-occurring disorders treatment can help inform us in thinking about services matched to patients' motivational level, comprehensive, that are integrated into the behavioral health setting and take a long-term treatment perspective. And we see how assessment, motivational intervention, psychopharmacology, and other techniques can be useful in helping patients work towards a tobacco-free lifestyle. One of the last points I would just like to remind people about is that there are important medication interactions that occur with tobacco smoke exposure. Tobacco smoke is an inducer of one of the liver enzymes. Specifically, it's the 1A2 isoenzyme. So as a result of smoking, metabolism of any medications that are impacted by 1A2 are essentially enhanced. This is a negative effect because this means it reduces the blood levels of people's medications, and smokers, in fact, tend to be on higher doses of these medications. Just by chance, it turns out that most of the medications that are affected by the 1A2 enzyme are psychiatric medications and include commonly used antipsychotic medications and antidepressants. Caffeine is also impacted by 1A2, and this is one of the reasons that smokers tend to be high drinkers of coffee and other caffeinated beverages. They're essentially drinking more to compensate for the rapid metabolism of caffeine that occurs as a result of smoking. The opposite can also occur when people stop smoking abruptly. They can be at risk for medication toxicity, where the levels of these medications can rise too rapidly. Out of all of the medications on the list, the one that is potentially most dangerous is clozapine, which has a risk for seizure with a rapid rise in blood level. You might consider dose adjustment in the context of someone quitting smoking and advise people to reduce caffeine intake, also in the context of quitting smoking. Remember that this interaction is not from nicotine or from nicotine replacement products. Nicotine is actually metabolized by a different enzyme, 2A6, and this is in fact a result of the tars in tobacco smoke that causes this interaction. So just to review, it's the smoke that kills. We've seen numerous consequences from tobacco use in individuals with mental illness. So think beyond the health consequences. Tobacco often impacts many aspects of life and of recovery. Mental health professionals should be more involved in tobacco treatment and treat tobacco like a co-occurring disorder. Program, system, and policy changes can be also helpful in supporting the treatment efforts of individuals. Thank you.